site frequently. So without further ado, I'd like to introduce our speaker. Um, oh gosh, now I'm going to get it wrong. Dr. Waqas
Yeah,
Malick,
Malick, yeah.
I just asked him,
Yeah.
is Director of Lipids and Cardiometabolic Disease of the Valley Health System in Paramus, and he is Assistant Professor of Medicine at Mount Sinai Foster Heart Hospital in Manhattan. So without further ado, thank you so much, Dr. Malick, and we appreciate you being here.
All right. Thank you, Susan. So, yeah, my name is Dr. Malick. I'm a cardiologist by training. During my fellowship, I was at Mount Sinai. I decided to train in general cardiology, but there's a new field that's emerging, mostly focused on prevention. And I spent an extra year learning a lot about these novel therapeutics and new methods of approaching cardiovascular prevention. I spent 2 years as faculty at Sinai. I still go there one day a week, and then decided to come out to Valley to help build a preventive cardiology program. So without further ado, I'll get started. So my goals for today, number one, would be to briefly discuss current approaches to understanding your risk for cardiovascular disease, how doctors use that risk to currently approach risk stratification. I'm going to introduce a more comprehensive approach to understanding cardiovascular risk, and then I want to introduce the program and how we approach patient care here at Valley Health System. So before I get started, I have to define, what is atherosclerosis? Atherosclerosis is really the formation of plaque in your arteries. So we are all born with native vessels with nothing on the inside except for muscular cells. And as we all age, we develop plaque over time, or gunk, that can either progress and eventually potentially even lead to clots when they rupture. We do know that the formation of atherosclerosis involves a lot of biological pathways. When we do genetic analyses, we've identified about 150 to 165 genes that are associated with the development of plaque. Now, about 15 to 20 genes are related to cholesterol. We have genes related to inflammation, as well as obesity, insulin resistance. But we also have genes related to how your vasculature responds to stress, how well your vessels dilate under stress, and then other pathways are uncertain for which we have no biomarkers or ways to identify your risk for disease. So when we define coronary artery disease risk, the reality is that your disease risk is actually a combination of your genetic risk enhanced or mitigated by environmental factors. We call that genetic risk polygenic, meaning many genes contributing to your coronary artery disease risk. And this is something you're technically born with. Over a lifetime, you can adopt either maladaptive habits such as eating poorly, leading a sedentary lifestyle, smoking, obesity, alcohol intake, and these contribute to risk factors, eventually contributing to disease or potentially even a heart attack as we age. We know that atherosclerosis and coronary artery disease exists along a spectrum. There are people who are at low risk that never develop any disease or plaque. There are people who are at risk. Usually diabetes is a big one, but other risk factors. There are people who have plaque already in their arteries or atherosclerosis, but have never had any heart attack or stroke. And then there are people we call the highest risk categories, people who've already had a heart attack or a stroke or some kind of what we call cardiovascular event. When it comes to understanding your risk, we traditionally go back to what we've always appreciated, at least since the 1960s, out of Framingham, Massachusetts, the standard modifiable risk factors. There are 5 modifiable risk factors. These include diabetes, smoking, high cholesterol or hyperlipidemia, high blood pressure or hypertension, and obesity/adiposity, which is a fancy word for saying fat deposition. And all of these 5 standard risk factors are what we traditionally use to estimate your risk. Now, the current approach we use is something called an ASCVD risk calculator. These take certain criteria such as age, sex, race, blood pressure, cholesterol numbers, diabetes, blood pressure, treatment, smoking status, and other medications into account. So if I give you an example, if I have a 64-year-old white male with the following numbers: blood pressure 134/81, not bad; LDL cholesterol 130, not bad; HDL 52, no diabetes, never smoked, and on 1 blood pressure medication, you might think you're pretty healthy. But in fact, your actual risk of having any heart attack or stroke within the next 10 years is 15.5%. And you can optimize that risk and reduce it to even 8% potentially with medications and lifestyle. So when it comes to standard modifiable risk factors, as a lipidologist, I tend to focus on the lipids first, as well as a cardiologist. Why? Because LDL cholesterol is absolutely necessary for development of plaque. Now, LDL is a lipoprotein that carries cholesterol throughout your blood, and it travels in and out of vessels. As it travels into the arterial wall, it can sometimes be eaten up by these inflammatory cells that tend to deposit what we call foam cells into the arterial wall. Over time, as this foam cell progresses, you can see the plaque tend to bulge inward into the lumen. And eventually, this plaque can progress so much that you may have what we call a heart attack or stroke. We do also know from genetic studies that LDL cholesterol is associated with lifelong risk. In the general population, we can divide people really into four categories based on cholesterol numbers alone. There are people who have severe high cholesterol since they're young. This starts usually in your teenage years, usually when a pediatrician checks it. There are people who have moderately high cholesterol. This really starts in your 20s, 30s, which is compounded by lifestyle sometimes. Most people in our society fall into this category, modest hypercholesterolemia. Average LDL in our society is 114. Sometimes lifestyle can make it worse, but this is a category, probably the most common category. And then there are people that we see regularly that have very lifelong low cholesterol due to their genetics or due to their lifestyle or combination, or they start therapy very young. Regardless, based on your LDL cholesterol, your risk for crossing the threshold for disease depends a lot on your genetics and your cholesterol since birth. So this is why our current prevention guidelines actually recommend that lowering LDL cholesterol is paramount. That's your bad cholesterol, especially when the LDL starts getting above 190, or if you have risk enhancers like diabetes, you should definitely think about starting medications. Another group to think about is something if you have, if you're based on the risk calculator, if you're at borderline to high risk, you may warrant starting therapy to reduce your risk of disease as well. And sometimes if you don't want to take medications, we do something called a calcium score to assess whether or not you're at risk, despite the risk score. What is a calcium score? A calcium score is a non-contrast CAT scan. So what that means is you go into a machine, no IV, no dye is given, and it takes literally a minute, and we take a picture. And a picture just tells us how many specks of calcium do you have in your arteries. And we circle that calcium and we come up with a score. And you can have either no calcium detected, or you can have a lot of calcium detected. What a calcium score tells you at the end of the day is how much calcified plaque you have, hard plaque. But it won't tell you if you have any soft plaque or soft blockages, and it won't tell you if you have any blockages at all. It just tells you how much calcium you have, which could be on the outside or the inside of vessels. But it helps determine risk. We do know as the calcium gets higher, you are more likely to have higher risk for heart disease. So what are some of the approaches to cholesterol management? Now, no doubt everyone's heard of statins. Statins have been around for 40 years now. The first ones really came out in the late 1980s. We have about 27 randomized controlled trials, almost 300,000 patients to show us that statins reduce cardiovascular disease risk. When you put all these trials together, we know that for every 40 milligrams per deciliter reduction in LDL cholesterol or 1 millimole per liter, you get a 21% reduction in coronary heart disease events. So this is, statins have been well established. Statins do three things. The first thing they do is they stabilize any soft plaque that you may have. So if you have any soft plaque, they help calcify it. Second, they help reduce the inflammation in plaque, so they prevent heart attacks or stroke. And third, they reduce the cholesterol, so it makes it more difficult to form new plaque. There are other alternative therapies, PCSK9 inhibitors. Some of you may have heard of Repatha and Praluent. Repatha and Praluent bind a certain protein in your blood called PCSK9. This is the drug. And when they bind the PCSK9 protein, you tend to clear more cholesterol from the blood because you inhibited PCSK9, the protein. But there's a new drug called Leqvio that instead of binding the protein in the blood, actually binds the message and prevents the protein from being produced in the first place, which I'll talk about. What this drug Leqvio is what we call something called RNA interference therapies. So it's the first iteration. What RNA interference therapy does is, so basically everything you are is a manifestation of a code. That's your DNA. The DNA can be subdivided into about 20,000 genes. Each gene leads to one message RNA, which leads to one protein. So what the drug does is it gets injected, it gets bound into the liver, it gets absorbed there, and as it's into the liver cells, it binds the RNA And instead of letting the RNA become protein, it leads it to cleavage and prevents it from making it into protein. And there are different forms of RNA interference therapeutics across different fields, but in cardiology and prevention, we usually talk about Leqvio. Another option for lowering your cholesterol is bempedoic acid. Bempedoic acid is an oral medication. It works in the same pathway as statins, but it affects a different protein, so it doesn't affect muscles and joints. So it's a very popular medication for people who have difficulty tolerating statins. And it reduces your cholesterol and reduces your cardiovascular risk as well. Why do we care about lowering cholesterol so much at this point? Is because we've established in many, many trials at this point that when on average people achieve an LDL cholesterol, meaning the bad cholesterol around 60 to 80 or really near 70, that is when on average most people do not achieve plaque progression, meaning the plaque is really neutralized from progressing. Now, there are some people who are very high risk that need to go even lower to prevent plaque progression, and there are some people who have higher cholesterol and never have plaque progression. It does vary by individual biology, but in general, we do know that on average, if you keep the cholesterol low, the ability to form plaque or have it progress is mitigated. So in summary, it's really never been easier to lower LDL cholesterol for prevention. There are many therapies. There are at least 10 different statins. There's ezetimibe, there's Nexletol, can be combined with ezetimibe as Nexlizet. There's Repatha and Praluent, and then there's Leqvio. And so, if you have issues lowering your cholesterol, you should definitely talk to your doctor about maybe some alternative options as well to prevent disease. Now, the next category for cardiometabolic disease, what I'm going to talk about, is diabetes and obesity, a big component of cardiometabolic health. In modern day society, it's never been easier to develop obesity and diabetes. These are foods that are frequently available to us. And to be honest, a lot of America is addicted to these types of foods in general. Why is this bad? Because the more types of food you eat, the more adipose tissue you develop. Adipose tissue is really just a fancy word for saying fat cells. So the more fat cells you have, the more hormones these fat cells release to stimulate you to want to eat more, leading to more fat cells. As you have increased fatty tissue develop or increased adipose tissue, it leads to eventually abnormal distribution. So what that means is that fat or that adipose can deposit in the liver, lead to fatty liver disease. It can deposit in the pancreas, leading to insulin resistance or diabetes. And it can deposit in the heart, leading to heart failure and arrhythmia such as atrial fibrillation. Furthermore, when you get insulin resistance, this tends to compound or make problems that you may not have had or develop problems and make them worse. So for example, the more insulin resistance you have, the higher your triglycerides, the lower your good cholesterol, HDL, and the higher LDL particles or more LDL you'll have floating through your blood. You'll have more inflammation. You'll have more inflammation in the arterial walls. And then on top of that, you'll have worsening beta cell function or lead to more diabetes. All of these things combine to lead to poor vasculature or vascular health, which leads to complications in your small arteries as well as your big arteries, leading to heart attacks, heart disease, and stroke. So when it comes to these things, we try to advocate lifestyle first. Before I just jump into the pharmacotherapeutics for diabetes and obesity, I would recommend that, we try lifestyle first. So I always recommend from a cardiovascular preventive standpoint to focus on a diet that's high in fiber and high in healthy anti-inflammatory fats. So fibrous foods include leafy greens, broccoli, asparagus, broccolini, spinach. It includes berries, so fruit with thick skin, apples, berries, pears, as well as oatmeal with seeds. Chia seeds and flax seeds have a lot of fiber, whole grains. And I recommend anti-inflammatory fats. The 5 fats I usually recommend are fish, particularly salmon, halibut, tuna, fish that swim in cold ocean water, avocados, nuts, olive oil, and seeds, chia seeds and flax seeds. So all these foods combined. I don't know what shirataki noodles are, but I did like this picture a lot. And Greek yogurt, when you combine it with a lot of stuff, can be very healthy because it's high in protein, nutritious, even though it's mostly saturated fat. You can always add chia seeds and blueberries and whole grains to help make it healthier. So what is obesity? Obesity is really just a result of what we call caloric mismatch. So everybody knows that calories in must equal calories out. So even if you eat McDonald's once a day, if you burn more calories than eating McDonald's once a day, you will maintain a certain weight. Now, I'm not saying that's what you should do to lose weight, but I'm just saying in general, the example of calories in equal calories out. The problem is, though, as we age, our ability to get the calories out declines. So a 22-year-old, if he sits on a couch and does nothing all day, may burn 2,500 calories, depending on his muscle mass. A 40-year-old will be down to 1,700, and then a 60-year-old will be down to 1,300. So your ability to get calories out without extra work or reducing caloric intake declines with age, which is why weight increases with age as well. A normal BMI, or body mass index, is 18 to 24, and obesity is when it gets above 30. But what we really care about, besides obesity, although weight's not good, is central obesity. Central obesity is when you have a large gut with a lot of visceral fat, with slim arms or slim limbs. And that is usually associated with the worst cardiovascular risk or cardiometabolic syndrome. Now, with respect to lifestyle, there are a lot of different apps and wearable tech that can help you track your calories and health. A lot of technology has emerged. There's Oura rings, Whoop bands. You can use healthcare savings accounts on these things, Apple Watches. There are apps like MyFitnessPal, which can help you track how many calories you're taking in. And there are continuous glucose monitors, which can help track, how much insulin resistance you're at risk for, depending on the glucose spikes you see after you eat. But of course, even if lifestyle interventions fail, the armamentarium to treat diabetes has expanded tremendously over the last 10 years. When I was a resident, all we had was really metformin, glipizide, repaglinide, and insulin. So I was titrating a lot of insulin as a resident 10 years ago. But now, with all the therapies, with GLP-1 receptor agonists, SGLT2 inhibitors, and there are many formulations of these classes of drugs already, we can get diabetes and A1C better controlled. Furthermore, there are drugs that help with cardiovascular risk, particularly GLP-1s and SGLT2s, drugs that help with heart failure risk, drugs that help with chronic kidney disease risk. And all of these, help prevent fatty liver as well. And then there are drugs that help with weight management. GLP-1 agonists reduce cardiovascular risk, even if you don't have diabetes. They definitely do it if you have diabetes, but they also reduce it if you don't. So Mounjaro, Ozempic, Wegovy, and Zepbound are the four. Ozempic and Wegovy are pretty much the same medication, just for different uses, and Zepbound and Mounjaro are the same. And if you see on the chart here, in the clinical trial in people without diabetes, just being on Wegovy reduced your risk for cardiovascular events starting at 1 year and was sustained long term, and also reduce your risk for death from any cause as well. So what is cardiometabolic disease? Cardiometabolic disease is really just combining all these factors, understanding your overall prevalence or risk for disease, and then treating each risk factor as its own disease process going on to help reduce your risk for overall cardiovascular health, or reduce your risk for overall cardiovascular disease. And so I divide it usually into 4 stages. Stage 1 at risk, stage 2 risk factors, stage 3 subclinical disease, which I'll explain, and stage 4 complications of that disease. So stage 1 at risk is usually defined by your genetics and your environment and your lifestyle. So there are some people who are at higher risk for developing metabolic disease depending on their ancestry. For example, like I'm of South Asian descent. People from my culture and background tend to have more diabetes or pre-diabetes, so that puts me at risk. But it can be compounded by environment and lifestyle. So you can not exercise and be more sedentary, or you can eat more poorly, or you can eat very healthy. So these things combine to give you some kind of risk for developing risk factors. Now, stage 2, which you're trying to avoid ideally, is the development of these risk factors. So you may just have dyslipidemia, or what we call high cholesterol, high triglycerides. You may have dysglycemia, or high sugar levels. You may have high blood pressure, or you may already be obese. These are stage 2 risk factors. Now, stage 3 is the risk factors are starting to cause problems. You detect plaque. Your calcium score is now 300, 400, even higher. And then stage 4 is you've gone beyond all of this, and you already have stents, bypass surgery, a stroke. You sometimes get hospitalized for heart failure. You've had atrial fibrillation. You've required ablations, or you may need a valve replacement. So our mission is to make sure you really ideally not progress beyond stage 3 to stage 4. But, I'll talk about that. And we treat all these stages by treating the risk factors aggressively. So I can treat diabetes now with an armamentarium. I can focus on A1C control. I can protect your kidneys. I can protect your heart. I can focus on your lipids. There are three major targets. I will talk about LPA in later, but LDL and triglycerides are well established. And then we can focus on obesity with the GLP-1s and bariatric surgery, and then blood pressure as we traditionally do. But the thing to be aware of is that cardiometabolic disease can be treated at any stage. 50% of people that have a heart attack had no symptoms prior to a heart attack, had no screening for subclinical atherosclerosis, had no calcium score. So some people just go straight from risk to having disease, a heart attack. Some people actually get a calcium score and develop disease. And some people actually, progress in a traditional way where they have risk, they have a calcium score, and then they still need stents. Even if you develop disease, we can still try to treat your risk factors so that you're back in stage 2 and you only have risk factors, so that you don't have recurrent disease. So I like this model because it allows me to think in a circular way of where can I get this patient in terms of disease process. And we do know that there are a lot of options for treating. When we say stage 1, which is primordial, which is at risk, we focus mostly on lifestyle. In primary, when you have risk factors, we focus on some medications to help treat those risk factors. If you have some plaque already or subclinical atherosclerosis, we can be a little bit more aggressive with our pharmacology. Of course, lifestyle is always a key factor. And then, what we really want to avoid is stage 4, so you're not getting recurrent stents and procedures, et cetera. What are some of the future approaches that we are thinking about trying to catch disease earlier? I would say CT angiography. Now, if you recall when I was talking about coronary calcium scoring, the problem with coronary calcium scoring is it only tells you how much calcium you have, but it won't tell you if you have any high risk plaque features. It won't be capturing risk in younger people who may be at disease risk based on other risk factors or numbers. So coronary CT angiography is you get an IV and we can give you some dye and you can see exactly what's happening inside the arteries. You can see if there's plaque developing that may not be calcified, et cetera. Here at Valley Health System, we use single photon counting CT. So this is the most advanced CAT scan machine that you can have. And we have it we're one of the few centers in the tri-state area to have it. And it provides extremely high resolution to detect any plaque within the arteries. And it can even do it in patients with very high calcium scores. On top of that, Valley, you do use AI to quantify exactly how much plaque you have in your arteries, how much calcified plaque, how much non-calcified low-density plaque you have to understand what your risk of disease occurrence lies at. One of the other things I mentioned is lipoprotein A. Now, this is a new novel marker that's been around for like 10 years, but it's really been catching in the world of academic cardiology and now more clinical cardiology. It's a genetic cholesterol protein. It looks like LDL, it's same density, but it's very atherogenic and it runs in families. So this cannot be modified by lifestyle, so a number usually remains the same, but it runs in families. And if you have a family history of heart disease, or you yourself have heart disease, you should have it checked. A lot of drugs are being established or developed right now. They're in phase 3 clinical trials. We expect the first drug to launch next year. And as LPA increases, your risk for heart disease increases significantly. So as LPA increases here, once again, you see that the curve shifting, the risk ratio increases, as well as if you have genes that lead to high LPA. So I just want to show you a case of how I think about cardiometabolic disease. This was a case of mine from Mount Sinai. This is a 38-year-old male. He has an autoimmune condition, ankylosing spondylitis, Hodgkin's lymphoma. He has familial hypercholesterolemia, and he had high lipoprotein A. His highest untreated LDL was 214. He had a genetically confirmed mutation. His calcium score was 57 at age 30, and he had an LPA of 190. His maternal grandmother died of a stroke in the 60s, and his family has all high cholesterol. So he's already currently taking rosuvastatin 40, ezetimibe 10, and Wegovy when he saw me, and he was on an anti-inflammatory medication. On exam, he was 278 pounds with a BMI of 37, so he was obese. His LDL was still 136 despite being on a statin and ezetimibe. His triglycerides were somewhat elevated at 131 LPA. His A1C was 5.6, which is borderline prediabetes. So how do I think about this case? Number one, I know that he already has plaque in his arteries. So am I doing everything I can to control his lipids, including the LDL? Should I add something else? Are there alternative options that can help him lower more beyond the statin? How should I consider the lipoprotein A given his genetic and he has this atherosclerosis in his arteries? Number four, what can I do about his BMI of 37? Will that help reduce his risk? And is the inflammation controlled given he has this autoimmune condition? So what he did was he actually had been trying Repatha with his referring cardiologist. He had side effects. Repatha was one of those medications that binds PCSK9 in your blood and reduces your LDL. So I actually put him on Leqvio or inclisiran. I also got him a full contrast CTA because I wanted to make sure he wasn't developing blockages. So he had a calcium score of 281 now, 9 years later. And his plaque was entirely calcified. So he had no high risk soft plaque and he had no intraluminal plaque really. The highest I think was 25 to 49%. They always give you a range. They never tell you exactly how much at other institutions. At Valley, we will tell you exactly how much. And so based on all the medications, I got his LDL down to 34 because like I said, he's a high risk guy. So I want him to like achieve plaque stabilization. His LPA down to 114 and his triglycerides were down to 91. However, when I saw him, in April, he was still kind of like still having a high BMI 37. His weight was relatively unchanged since December. So I actually switched him to Zepbound. And that sometimes happens. For some reason, some people could respond to one, but not the other. And so when I saw him in October, his weight was down to 247. So he lost almost 30 pounds. His inflammation was okay, 6.5. But, he was feeling much better. He was much happier. And I actually increased his Zepbound because his goal weight was about 220 on the at a height of 6'1", if not lower. So here at Valley, traditionally we've always focused on primary care as being the gateway to your risk and understanding your risk. But as these fields advance, we know that primary care doctors can't take care of it all. And we here are a team. I work very closely with a lot of the primary care doctors. There are endocrinologists to help manage insulin resistance and diabetes. We have a weight loss center to help you lose weight if you need to. And then with our emergency here in cardiology, the Lipids and Cardiometabolic Disease Program, we can take all these factors combined and help you reduce risk and screen for heart disease so that you may never need cardiology interventions, or if you've already had them, to prevent the need for recurrent interventions. So in conclusion, coronary artery disease risk is heavily dependent on one, genetics mixed with environmental lifestyle factors. Cardiometabolic disease is the interplay of lipids, insulin resistance, obesity, high blood pressure, diabetes, diet, exercise, and to lead to development of disease. We have newer technologies and biomarkers that can help you improve risk stratification beyond just the numbers and allow us to be more definitive rather than being probabilistic. And the new Lipids and Cardiometabolic Disease Program aims to help currently established programs and providers in preventing the need for recurrent long-term interventions in patients. Thank you. Happy to take any questions.
Thank you so much, Dr. Malick. That was really interesting and so comprehensive. Just a couple of questions, if you have a few minutes. One of which is, you might have answered some of this, but can a patient's HDL number um, be too high to be healthy?
So that's a great question. So HDLs, unfortunately, the answer is no. I've had patients with HDLs of 140 that are totally healthy. And I've had patients with HDLs of 110 that it might have plaque. The problem is HDL cholesterol itself is not necessarily predictive of cardiovascular risk. Now, the only time it is predictive is when it's very low. So if you're a male with HDL cholesterol less than 40, it's really bad to have that. If you're a woman with HDL less than 50, that's high risk. And then the third thing I will say is the HDL to LDL ratio also plays a role. So sometimes I'll see a patient with an LDL of like 120, but their HDL is 30. So that ratio is 4-1, LDL to HDL ratio 4-1. That's for high risk. So what you really need to know, if you're worried that your HDL is too high, then there are two either solutions, or you can do both. The first, you can just get a calcium score to see if you're developing plaque despite this HDL being high. If your calcium score is high, that means the HDL is relatively dysfunctional. Or you can get an NMR lipo profile and get an assessment of how many HDL particles you have. Now, particles are a better indicator with HDL because they tell you, how many HDL particles you have that are participating in reverse cholesterol transport. Meaning the function of HDL is to take cholesterol away from the bad cells and bring it to the liver for clearance. So if you have a high number of particles, you have low risk. But if you have a low number of HDL particles, despite having a high HDL cholesterol, you're at higher risk. I hope that wasn't too
That makes sense.
sharp. I hope that made sense.
It does. Okay. So let's see. Somebody has a question about kind of specific, but if you have an HDL of 90, calculated LDL is only slightly higher than normal, so possibly contributing to a total cholesterol of about 120, and there's no other cardiac issues, would it be recommended for a statin if it's a little bit higher than the ideal amount, number? What do you think?
That's a great question. Number one, I don't usually go by, so,
Hmm.
I see this a lot where people are, tend to recall their total cholesterol. Total cholesterol is not a great marker of risk because of exactly this example, right? So if your HDL is high, then your LDL is going to be probably normal or slightly higher than normal, which is correct. So the total becomes kind of irrelevant in that case. Now, should you be taking cholesterol lowering medication without any other issues? That's a question that's a relatively debated issue.
Hmm.
Some people would argue that keeping the LDL low, regardless of the HDL, is warranted or is worth it. Um, Having said that, there's no definitive evidence that you absolutely need to take medication in this specific scenario. A statin would not increase HDL. It would actually lower the HDL because what statin does, it reduces cholesterol production and improves cholesterol clearance. So what statins do is they preferentially lower LDL by about 40 to 50%, but they also reduce HDL by about like 5%, So they improve the ratio. But in this case, unless there's some overt reason to require cholesterol lowering medication, you can hold off.
Okay. If you are at risk, is the coronary CT angiography mentioned covered by insurance to your knowledge, if
Um,
there's a high risk?
so coronary CT angiography is covered by Medicare. So you don't need a prior authorization if you have Medicare. You can get a coronary CT angio to see exactly how much plaque you have. Um, and in fact, if you're going to get I usually would tell my patients personally that if you're going to get a calcium score above the age of 65, I'd rather just get the CT angio because the calcium score is going to come back positive and no one's going to know what to do with it, or somebody might panic. So it is covered by Medicare. Right now, there are a lot of clinical trials going on, um, namely Scott Hart 2, and then also Transform. They're trying to prove that screening CTAs in higher risk people should be covered by insurance, but those trials are still ongoing. But if somebody's high risk, you can usually find a way, like the traditional method, the traditional, cardiology has always been like, oh, you're at high risk. Let me just do a stress test and make you run on a treadmill. But a stress test only detects blockages if they're more than like 70% or higher. What you want to do is capture plaque at 20% or 30% and make sure it doesn't progress to 70% or suddenly rupture and become a full on heart attack. So a stress test is not great, in my opinion, for screening for disease. So sometimes if
Hmm.
you're really, really high risk, we can find a way to get CAT scans covered by insurance. But in general, they're not like covered blanket wise, which is why people still use calcium scores, unfortunately, for our society.
Okay. Couple questions about the GLP meds. Um, will the efficacy of, say, a GLP med like Mounjaro ebb over time, force them to increase dosage, and any idea of how long someone with a cardiac condition could be safely be on Mounjaro or a
Okay,
GLP
yes.
med?
Um, so that's a great question. Number one, so far, to my experience, I've been using these drugs now for like four years, or 5 years now, I guess. So yes, I have not seen the efficacy ebb over time.
Mm.
Okay. Now, people respond differently to different doses. So, for example, like we all know that the lowest dose, 0.25 or 2.5 for Manjaro or 0.25 for Ozempic, that's just an introductory dose to get you used to the effects. Um, but some people have a tremendous response to these drugs at like, zero point 0.5 or 5, and other people need to go to max dose and have a good response. Sometimes, the other thing I would say is from a diabetes perspective and weight perspective, it's very interesting actually. Diabetic patients get a great response for A1C, but they don't lose as much weight, whereas obese patients lose more weight um, with Zepbound, which is interesting because the drug is technically the same, and I don't think we fully understand why that is. So I've seen people on Manjaro 15 not lose much weight, or ideally as much weight as we would have liked. Um, so with regards to safety, so far everything looks like the safety's been established. The main thing is the problem is that if you have any family history of like multiple endocrine neoplasia or medullary thyroid cancer, that's something that's a contraindication. Uh, One thing I will say is, there's always this risk of potential pancreatitis. The one thing I get concerned about personally, and I can't back this with clinical evidence, so take this with a grain of salt, um, is that we don't know long term, given the effect of how it works, um, if there's going to be gastroparetic effects. So basically, what I'm saying is, your digestive tract works through a mechanism called peristalsis. You eat some food, and that food is moved along through the muscle of the intestines through a mechanism called peristalsis. Now, if you stop eating, I'm not saying it's to affect the drugs, but you're not eating as much, and you're constantly on a low-calorie diet, eating 700 calories, 800 calories a day, will that eventually cause gastroparetic problems or gastroparesis, as we call it? That I don't know.
Okay.
I have a question here for the LPA.
Okay.
So I want to answer that.
Yeah.
I have some time, Susie. I can answer a lot of these questions.
Okay, that'd be great. You
The,
screen
the,
them and go right ahead.
the BMI is usually calculated by just entering your weight and height into an online calculator. So that's very easy to do. Just Google BMI calculator. With regards to LPA, LPA is genetic. There is some variability in measurement to measurement. We don't fully understand why. Sometimes having a high CRP or if you have a cold might increase the LPA, but it is set for life. So if you come in with an LPA of 200, which is very high, and it jumps to 250, it doesn't really matter to me because you're still very high. You're in the 99th percentile. The LPA can be reduced with PCSK9 inhibition medications. But what academics, and to be honest, what we all argue is that reduction is not sufficient enough to reduce the risk. Some people believe that LPS to be reduced by at least 60% to reduce that risk in high risk people. And so our first clinical trials, which should be announced soon and then presented in the fall, will show exactly how much risk reduction we achieve. So current medications that reduce LPA in the market are just the PCSK9 medications, but nothing else. But we hope that next year we'll have medications that reduce LPA by 80 to 95%. I can't really answer personal questions. But I can answer his red yeast rice question. So red yeast rice is just a very weak statin. If you're going to try red yeast rice, I'd rather you just try a very weak statin like pravastatin or simvastatin. Why? Because red yeast rice has no outcomes data. It's not regulated. It's a supplement. You may get a bad formulation. I'd rather you just try pravastatin or simvastatin if you're that concerned about trying statins. Most people tolerate low intensity statins very well, and even moderate intensity. The problem with statins historically has been is that we've always prescribed high intensity, high doses first, because usually the people who get prescribed statins for the longest time in history were always people who had a heart attack or stroke, who always get put on the highest doses first based on clinical trial evidence. But low intensity and moderate intensity statins are very well tolerated. So I think there's really no reason to try red yeast rice unless the patient feels very stubborn about it. Yes, family history for women should be taken just as seriously as men. Doesn't really matter to me. It is not, cardiovascular disease does not discriminate by gender. The only difference is that maybe the age of presentation may be slightly delayed compared to men. So if your father had a bypass at age 60, and you're a woman, you might have, you may be on the way to having bypass yourself or stents by age 70. But, it does not, the risk is still there. We don't really use apheresis for LPA at this point because the drugs are so close. I don't think I can really think. In my time, you can see that I'm relatively young. I've actually never seen a case of lipoprotein A apheresis. Can you get accurate readings if you're on a statin? I don't know Daniel, what you mean by accurate readings, or accurate readings of what? Um, Janice, what's your assessment of somewhat elevated LDL and a calcium score of 0? So that's a great question. And this is actually a very common source of referral. One of the things we know about LDL cholesterol is that even if it's not contributing to disease necessarily for your first 70 years of life, you've obviously established that you may be a low risk. The problem is with calcium scores at a certain age, they're not the best indicators of risk because the risk score already tells you you're high risk. So there was a study, I actually had that slide, I took it out because I thought it was gonna be too complicated, but at age 70, you're already what we consider to be high risk based on age alone. So it's reasonable to keep that number a little bit lower, just to maybe prevent any disease events, because plaque can still progress and happen and may be soft. So it's reasonable. So you are a candidate based on your risk score. The calcium score helps to say that you might be low risk. In that case, if you want to be absolutely definitive, and I have seen patients like this, is you could get a CT angio. And if you have absolutely no plaque at all, then you obviously don't need a statin, because a CT angio pretty much means you're clear for like the next 10 years. Calcium scores 110 is nuclear stress test recommended. So any calcium, that's a great question. Historically, we used stress tests to try to capture disease. Now, stress tests have a lot of false positives and false negatives. What that means is you get a stress test and it might tell you have disease when you don't. And false negative is, a stress test might say you're normal even though you have disease. A calcium score is just a risk score. It doesn't tell you whether or not you have true blockages. And a stress test is, telling you, if you have true blockages. So what changed over time was we had a couple of clinical trials. So in the 1990s and 2000s, everyone was getting stents, 50%, 60%, you just got a stent. And cardiologists made a lot of money back then by just putting in stents in all plaque as much as they could. And then there was a trial that came out called Courage. Courage said that, basically the only people that really need stents are people at high risk, meaning their plaque buildup is more than 70%. They should probably get stents. But people weren't satisfied with that answer. So then they did a trial called Ischemia, which was published in 2019. Ischemia said, okay, let's ignore the anatomy and let's just look for people with severe blockages based on stress tests. Okay, so moderate to severe ischemia, meaning you have a lot of blockages in your arteries. What happens if we put stents in these people? And what they found was they really didn't make much of a difference. The only time they made a difference was if you had symptoms, because then you'd at least improve the quality of life and reduce the symptoms from having chest pain, etc. So now I don't really do stress tests, regularly for patients. Actually, I've actually moved away from that in my practice, because I don't think that it's really helping unless you have symptoms. Then we can see if you have a blockage. And if you do have a blockage, then you can possibly benefit from a stent, or we can try some medication. So this is kind of a debate. I think some of the older cardiologists still do a lot of nuclear stress tests for calcium just to make sure you don't have a blockage developing. But with CT angio, especially at Valley, I like the CTAs better just to make sure, because that can save you from getting a catheterization unnecessarily. I left my phone number on this final slide. I don't know if I'm still sharing the screen. There is an apolipoprotein B. A great question. ApoB is a marker of total cardiovascular risk from your lipids. So if you remember, there was one slide I showed 3 bad cholesterol: LDL, triglycerides, and lipoprotein A. ApoB is kind of a summation of your risk from all of those combined. So if your LDL is like 140 and your ApoB is 90, you're actually a low risk person because all you have is LDL. But if your ApoB and LDL are almost 1-to-1, you're actually a higher risk person because you have multiple other factors involved. The triglycerides are causing problems, the LDL is causing problems, LP is causing problems. So yes, in my clinic, do I check ApoB? Yes. Does everyone do that? Probably not. It is actually not standard of care in the US. It is standard of care in Canada, interestingly. Yes, the alternative drugs are much safer with respect to CKs, particularly PCSK9 inhibitors. Great question. So high calcium score for me, without symptoms, without stents, without stroke, puts you in stage 3, not 4, because you don't have complications of disease. You just have subclinical atherosclerosis. Now, LDL less than 40, triglyceride HDL less than 1, stress crest, LP less than 10. So, at this point, you're doing everything right. I can't really recommend anything else. Can statin impact arthritic joint with traumatic? I don't understand that last question. Sometimes statins can cause arthralgias or joint pains and muscle aches that may mimic arthritis. Uh, if that's the case, you should probably just try holding the statin and see if it improves. If it doesn't improve, it's probably not the statin. But back to the main point, I just want to make sure is that stage 3 disease. We're just trying to make sure you don't need bypass and stents. One thing I want to say, one big caveat, depending on age, it may be unavoidable based on your genetics, because maybe we don't have all the therapies. I do have some patients, that sometimes have like a calcium score that's very high, despite doing everything I can, even when the LDL is like 20, and we don't fully understand the genetics. Like I said in my first slide, there are other markers that we don't fully understand. Yes, there are quite a few studies that show that, when you go off GLP-1s or GLP-1s, a lot of people tend to bounce back. That's why something I'm seeing actually increasingly utilized is what we call microdosing, where you, instead of taking it every week, you start taking it once in a while, like once a month, maybe every other week, maybe every like 10 days, at a lower dose to prevent that bounce back. Simvastatin. I don't recommend simvastatin. It's like the oldest statin in the book. It's very, I just don't like simvastatin. Highest rate of side effects. Pravastatin is water soluble. You take it at night, 10 milligrams, low half-life. No side effects of nuclear dye, but you are emitting radiation for the first 24 hours. We recommend not going near pregnant women or children after a nuclear stress test. Which risk reduction approach is better? So to me, this is actually, surprising the calcium score is 0, but I would not hang my hat on that too much. I'm reading Francie's question. So she asked, which risk reduction approach is better? GLP-1 or, by the way, can you guys see the questions, or am I just,
I don't know if they can see all the questions. So yeah,
oh, okay, sorry, I should have been reading them.
no, you've been kind of alluding. Go ahead.
Okay. Francie asked, which risk reduction approach is better, GLP-1 or metformin plus statin? 70-year-old, A1C 5.8 to 6, so pre-diabetes, calcium score 0, low HDL at 34, LDL 135 with a very high LDL particle number, so probably high concentration of small, dense LDL particles. I would probably argue, in this case, I wouldn't look at the question as better, because BMI is 27, but to me personally, I think I would definitely do the statin for sure based on these numbers alone, despite the calcium score 0, especially at relatively younger age. I think a GLP-1 would probably be better because there's cardiovascular outcomes data for it. Metformin, there is some support, but GLP-1s have better data. On top of that, the GLP-1s would inevitably help with the high triglycerides. If you have low HDL, I assume high triglycerides are present as well. So the GLP-1s would help with that as well, in addition to the statin. So I would do a statin plus GLP-1 combination here. Is there a known link between LPA and aneurysm? No known link, but given how vascular disease is all intertwined, I think it's probably there's some linkage there. But LPA is mostly known for its linkage with coronary artery disease, aortic stenosis, stroke, and peripheral artery disease. So if you had a family member or anyone who's had an aortic valve replacement, it's also reasonable to get LPA checked in that population. And Joan, thank you very much. Point of information, shirataki noodles or pasta is mushroom pasta, which is very low in carbohydrate or glycemic index. So thank
Oh,
you.
oh, thank you so much for answering all those questions, Dr. Malick. It was really appreciate it. Thank you so much.